Fenestrated needle is designed to perform nerve blocks without immediate proximity or contact between the injecting needle and the nerve. In this section, we will demonstrate how the fenestrated needle may facilitate femoral nerve block. In this diagram of the inguinal region, we see the positional relationships of the femoral artery, femoral vein, and femoral nerve at the level of the inguinal ligament. Note that the femoral artery and femoral vein are superficial to the fascia iliaca, while the femoral nerve is deep to this fascial layer. In the lateral portion of the inguinal region, the fascia lata closely overlies the fascia iliaca. However, moving from lateral to medial, these tissue planes divide, with the fascia lata passing superficial to the femoral vessels and the fascia iliaca passing superficial to the femoral nerve and deep to the femoral vessels. In this fresh cadaver dissection of the right inguinal region, we see the femoral artery and femoral vein retracted by vessel loops. Immediately lateral to the femoral artery and visible through the intact and translucent fascia iliaca is the femoral nerve. The overlying fascia iliaca is held with forceps. This dissection illustrates how closely the fascia iliaca adheres to underlying structures such as the femoral nerve and the iliopsoas muscle. This diagram illustrates how injection precisely deep to the fascia iliaca can produce extensive distribution of local anesthetic. The spread of injectate immediately deep to the fascia iliaca facilitates femoral nerve block without having to have immediate proximity between the injecting needle and the nerve. Although injection immediately deep to the fascia iliaca is highly effective, it can be technically challenging. On the left panel of this slide, we see injection lateral to the femoral nerve in a plane superficial to the femoral nerve and femoral artery. The distribution of local anesthetic in this plane is ineffective. On the right, the same injection is performed. However, in this case, the needle is advanced through one additional tissue plane deep to the fascia iliaca, which produces completely effective distribution of local anesthetic, which spreads over the femoral nerve and deep to the femoral artery. When we compare these two injection patterns side by side, we see that on the right, local anesthetic passes over the nerve and deep to the artery. This pattern is consistent with correct placement deep to the fascia iliaca. Although injection deep to the fascia iliaca and lateral to the femoral nerve is an attractive alternative to direct contact with the nerve, it can be difficult to perform. The image on the left shows a confluence of the fascia iliaca and fascia lata that is relatively easy to see with ultrasound and is demonstrated by the white arrows. However, dissecting these two layers, as seen on the right, can be difficult. This is in large part due to the challenge of positioning a single bevel needle precisely between the layers of the fascia iliaca and the fascia lata. The pencil point fenestrated needle can facilitate injection of local anesthetic into the correct fascial plane by providing visual and tactile feedback as the needle is advanced, as well as by providing increased flow through side ports in the needle. In the case of the femoral nerve, this can be accomplished with either a 2 or a 4-port needle. In this ultrasound image, tenting of the fascia with the pencil point needle is demonstrated. This tenting gives reliable feedback of needle position as the needle is advanced across the fascia iliaca at the lateral 1/3 of the image. This ultrasound shows a 20-gauge fenestrated needle, which is 1 centimeter and 4 side ports, as it is advanced across the fascia iliaca approximately 1 centimeter lateral to the femoral nerve. Notice that we have tenting of the fascia, and it displays the position of the needle relative to the nerve. Tenting also indicates when the tip of the needle has crossed the fascia iliaca. Injection of 20 mL of local anesthetic produces an easily visualized volume of local anesthetic in the correct tissue plane immediately deep to the fascia iliaca. This is one more example of a 20-gauge fenestrated needle being advanced across the fascia iliaca approximately 1 centimeter lateral to the femoral nerve. Again, tenting of the fascia iliaca is easily recognized as the pencil point tip crosses the fascia iliaca. Injection of a 20 mL volume produces a large hypoechoic area deep to the fascia iliaca, demonstrating a significant volume of local anesthetic in the correct position over the nerve and under the artery. The fenestrated needle is just one more tool to facilitate femoral nerve block while maintaining a safe distance from the femoral nerve.